Transplantation has been one of the bedrock therapies in lymphoma, for well over 20 or 30 years. And certainly the randomized trials have really highlighted in specific patient populations, so in the relapsed refractory setting, in Hodgkin's lymphoma, the relapsed refractory setting, in aggressive non-Hodgkin's lymphoma, phase 3 trials have demonstrated that autologous transplant is superior to standard of care therapy with conventional chemo. That being said, we're forced to look at these questions again as novel therapy has changed primary treatment and now has potentially changed how effectively patients may be managed in the relapse setting. And so the question first comes up, in the potentially curative setting, how do we integrate those agents around transplant? Because unfortunately, a lot of the patients you want to transplant don't respond to therapy before the transplant. And so integrating newer drugs there, again, in Hodgkin's lymphoma has looked quite successful. We've struggled in that area in non-Hodgkin's lymphoma, particularly in the aggressive setting. But maybe there might be a pathway forward there. And so, again, the alternative approach is when you're looking at patients who have been transplanted, again, is there a way to reduce the risk of relapse? And again, you've seen in Hodgkin's, the establishment of brentuximab as maintenance in that setting has actually improved outcome, where unfortunately, again, in diffuse large B-cell lymphoma in the relapse setting, we really haven't seen anything change that standard. The interesting thing moving forward, I think, will be seeing how newer therapies might compete with that platform. And so one of the interesting things is looking at CAR T cells, where you see very impressive activity in patients who were ineligible for transplant or had relapsed after transplant, where, again, complete remissions at 1 year potentially might be in the range of about 50%. And so I think this then leads to potentially an alternative strategy that could be evaluated against transplant. But given that transplant remains a treatment with a lot of history behind it and certainly does cure a proportion of people, one will need to do very well designed studies to try and replace a standard such as that.